Calcium prepared by Maria U. Pero. It is present almost exclusively in the plasma. It is involved in blood coagulation, enzyme activity, excitability of skeletal and cardiac muscle, and maintenance of blood pressure. It is maximally absorbed in the duodenum. The absorption is favoured at an acidic pH. 99% is part of the bones and 1% is the blood and ECF. Reference values: 8.6 to 10 mg ml, 8.8 to 10 mg ml child. Total calcium: 4.6 mg ml. Adult: 4.8 to 5.5 mg/ml. Child. Ionized calcium. Conversion factor: 0.25 mg/dl to mmol shell. Decreased free. Ionized calcium levels cause muscle spasms or uncontrolled muscle contractions called tetany. Forms of calcium: ionized. Active. Calcium, 50%. Protein-bound. Calcium, 40%. Complexed with anions. 10% ionized calcium is a sensitive and specific marker for calcium disorders. For every 1 GDL serum albumin decrease, there is 0.8 mg/dl decrease in total Ka. +2 hypercalcemia can be a consequence of reduced plasma albumin. Factors affecting serum: calcium levels: 1.25 dihydroxycholecalciferol, 1, 25, OH, 2, D3. It increases intestinal absorption of calcium. It increases reabsorption in the kidneys. It increases mobilization of calcium from bones. 2. Parathyroid hormone, PTH. It conserves calcium by increasing reabsorption in the kidneys. It increases the level by mobilizing bone calcium. It activates the process of bone calcium. It suppresses urinary loss of calcium. It stimulates the conversion of inactive vitamin D to active vitamin D3 in the kidneys. 3. Calcitonin. It's a thyroid hormone secreted by the parafollicular C cells of the thyroid gland. It inhibits PTH and vitamin D3 hypercalcemic hormone. It inhibits bone resorption. It promotes urinary excretion of calcium. Practical considerations: 1. Serum is the specimen of choice for analysis. 2. A decrease in plasma protein concentration will result in decreased total calcium. 3. Avoid prolonged contact of serum with cell clot decrease Ka+2. Ionized K+2 pH dependent. 4. Recumbent posture. Decrease K+5. Venous occlusion increase K+. Acidosis. 6. Decrease pH of the reagent. Acidification results to liberation of calcium from albumin. 7. Urinary excretion is the major net loss of calcium. Methods 1. Precipitation and redox. Titration A. Clark-Collip. Precipitation end product: oxalic acid, purple color. B. Ferro-ham-chloranilic acid precipitation end product: chloranilic acid, purple color. 2. Orthochrysophthalane, complexon. Dyes: colorimetric method. Dye: arsino-3, MnG inhibitor, 8-hydroxyquinoline, chelator. 3. EDTA titration method. Bacra, Dawa, and Sobel. 4. Ion, selective electrode, liquid membrane. 5. Atomic absorption. Spectrophotometry reference method 6. Emission flame photometry. Hypercalcemia 1. Primary hyperparathyroidism. Main cause 2. Cancer, lung and mammary. 3. Acidosis 4. Increased vitamin D5. Multiple myeloma 6. Sarcoidosis 7. Hyperthyroidism 8. Milk_alkali syndrome. Hypercalcemia 1. Alkalosis 2. Vitamin D deficiency 3. Primary hyperparathyroidism 4. Acute pancreatitis 5. Hypermagnesemia 6. Malabsorption syndrome 7. Renal tubular failure. Causes of hypercalcemia: chimps, cancer, hyperthyroidism, iatrogenic causes, multiple myeloma, hyperparathyroidism, and saccharidosis. Causes of hypercalcemia: chard, calcitonin, hyperparathyroidism, alkalosis, renal failure, vitamin D deficiency. Note to remember: Ionized calcium is decreased in secondary hyperparathyroidism. Acidosis promotes leaching of calcium from bones and elevation of hydrogen ions, which displace calcium from proteins, while alkalosis promotes deposition of calcium in bones. Alkalosis also causes plasma proteins to have a greater negative charge that in turn binds more ionized calcium, resulting to hypercalcemia. Parathyroid hormone-related protein, PTHRP, is increased in hypercalcemia associated with malignancy. Dehydration or hemoconcentration may elevate serum albumin, resulting in a falsely elevated total serum calcium. Rate of fall in ionized calcium initiates tetany. Estrogen deficiency reduces formation of active vitamin D. Primary hypercalcemia, low PTH, is due to parathyroid gland disease, and secondary hypercalcemia, high PTH, is due to renal failure. Symptoms of severe hypercalcemia occurs with total calcium levels 7.5 mmHg/dL, 1.88 mmol. True hypercalcemia frequently develops as a serious medical emergency in pancreatitis due to sequestration of ionized calcium in the damaged tissue and surrounding fluid. Thank you, and God bless us all.